of neck, at the level of mandible. Um, I can see that in the axial section there is uh, paravertebral increased soft tissue opacity with a narrowing of causing severe narrowing of the airway, and there is ipsilateral destruction. Uh, there is adjacent vertebral body destruction, um, and uh, it is of low density. Um, and adjacent vessels are seen normally enhancing. And a metallic artifact is seen in the left molar region.
Do you,
On
do,
the
sorry, do you want to scroll through the images?
I tried, but I'm unable to scroll, so I assume
Oh,
that they are not scrollable.
no, no. Okay,
Okay,
so
sorry, sorry.
I can do that
Okay,
for you. Okay,
okay.
here. Wherever you want me to stop, just tell me to stop.
Okay, so this is causing destruction of the adjacent vertebral bodies, and it's a large soft tissue opacity seen in the paravertebral region, causing severe narrowing of the supraglottic region. There are multiple enlarged cervical lymph nodes as well. So I like to know the age of the patient. Um, it's
It's
if it's an
61.
elderly patient, it's sorry.
61.
Okay, so I can I try to scroll it?
Yes. And do you want to see something else? If you want to see something else, then I can bring it for you.
Yeah, I think I am unable to scroll.
Okay.
Okay, so it's a soft tissue density aggressive mass lesion involve causing destruction of the vertebral bodies, and I want to see the superior extension of this and inferior extension of this mass into the glottic region. Um,
Do you want to see any other images?
yes, I can. I want to see sagittal image as well.
And sagittal in what?
Sagittal post contrast.
No.
Yes, so they see two vertebral body destruction and a large soft tissue mass, causing narrowing of the airway at this level. However, the nasopharynx appears unremarkable. Clivus is normal, and the visualized venous sinuses also
Do you
appears to
want to
be
see
normal.
bone window?
Yes.
Okay.
All right. On the bone window, there is destructive mass lesion of C2 vertebral body with adjacent soft tissue density mass. Um, it's an aggressive process. My differentials will include uh, it could be a bony lesion with adjacent soft tissue mass, or it could be vice versa, a soft tissue mass with the bone involvement. However, it looks more like primary bony with soft tissue extension. So, my differentials could include um, plasmacytoma, or it could be a metastatic deposit as well. And I will inform my findings to the referring clinician and will advise biopsy for the definitive diagnosis. And I will also advise the MRI spine to look for any other lesion in the bones, and also advise bone scan to see the multiplicity of the lesion. And if there is no known primary, then staging CT would also be helpful. Staging CT, chest, abdomen, pelvis.
Okay. It's a good description. You caught the finding, you appropriately, you try to make it something of the larynx, but then So requesting appropriate imaging. I'm just going to be giving you feedback as we go along because then I'm going to forget everything I need to tell you.
Yeah.
Is that okay with you?
Yes, ma'am.
Okay, so there's one important finding. Most of the cases today, it is for you and all other candidates are based on emergency. So there is going to be more because these are the cases that if you do not say certain things, even though your description is correct, differentials, diagnosis, everything, you may not pass the exam. So then we don't understand what happened. So
Yeah.
here there is an obvious problem is the spinal canal. See that?
Yes. Okay. Yeah. There is extension into the spinal canal.
The airway is not the problem, but this is
Yeah.
the so the mass is really causing significant compression of the cervical cord, and this patient could become quadriplegic because of where this thing is. So, in fact, this finding was considered so serious that she was immediately taken to surgery, and they did surgery for her. Like they didn't do anything else. They said, first of all, we need to take care of this, and then we're going to see what this is. So for midline masses, you have to have a
Mm.
very good differential. Your differential was really good. You did the case good, but the this was a chordoma.
Mm.
So for
I think.
midline masses, always remember METS was okay, plasmacytoma was okay, and then remember the chordoma. So I'm going to show you a companion case here because one pathology of one kind is okay. I don't want to show too many pathologies of the same kind. So I'm just going to show you this. I put a companion case for you here. So this is the MR of a sacrococcygeal chordoma, basically. So let's see. Okay. So you see this again midline
Yes.
and see the destruction.
Yes.
So this could have like also midline masses. So whenever you see a midline mass, always consider that chordoma could also be one of the
Mm.
diagnoses. And then you know because of the origin of this tumor, it is usually it has this T2 bright thing. So this is the post contrast. This is the T2. Let's see. Oh, must be T2. This is this T1 stir. I think yeah, yeah. So this is a stir image, and you can see the way this tumor is. There are few tumors that are bright on T2, and this is one of
Mm.
them. So you can
Yes.
easily suggest the diagnosis just from it, and then you see how it is like this.
Yes.
So yeah, so this is just a companion case for you. I just thought I'd show you this as well, just like that. Okay, so I'm going to bring up your second case now. So I think I would show each candidate 3 cases and then we can see what time we have. Okay, so try controlling again if you can
Okay.
to see if you can scroll. I'm leaving the mouse. Can you do it?
Um. Yes. I think.
Okay, let me scroll for you. Okay, so this is a 23-year-old male and has severe abdominal pain. So again, was brought to the emerge.
All right. So I'm presented with CT scan, abdomen, axial sections. The multiple fluid-filled bowel loops are seen in the abdomen. There is a thickened bowel loop seen in the left, uh, along in the left iliac region, along the left iliac blade. It has a bowel within bowel appearance with a well-defined lesion seen in the end. So I think it is a sepsion, and I'm looking at the lead point. This lead point has a lamellated appearance Um, I'm thinking it could be a gallstone as well. However, there is no adjacent bowel obstruction. However, it is causing intussusception of the bowel loops. These are the ileal bowel loops, and there is no cross ascites. So there are bowel loops, these intersuscepting bowel loops, so normal wall enhancement. There are no signs of bowel ischemia. So I'll pick up the phone and immediately convey my findings to the referring clinician, as it's likely intersusception, likely due to a well-defined lesion. Uh, it could be due to gallstone
Are you talking
or
about this?
on the cornel, this rounded lesion. Yes, this one.
This is this thing, huh?
Okay, yeah, it's elongated, so it's interception. And yes, so I think it's a benign looking fluid density lesion.
And what do you think it is?
Um, okay, it's a blind-ended tubular structure. It could be it could be Meckel's diverticulum, but I want to see its origin.
Okay, so
But
is
my that's mainly on the right side. Yes.
is there any clue on these images of what this could be?
Can you scroll again? I'm just seeing the whirling of the vessels.
Okay, so you have to look in the rest of the abdomen too, right?
Yes. Appendix looks normal. There's
No.
whirling of the vessels, and I think it's a blind ending structure going from right abdomen into the left side.
Okay,
It could
so
be,
uh,
yeah.
what's your management and
This needs immediate management for the interception, as it could lead to bowel obstruction and necrosis of the bowel loops.
I told you the patient has severe abdominal pain. So
Yes. So uh, I'll look for any thrombus in the vessel, which I am not able to find. However, it could be a benign cystic lesion.
okay,
There's
so
mild reactive ascites seen around it.
so what's your now management? What is the management?
Management would be, I will discuss the findings with the primary team, and this could need immediate laparotomy for the management of interception.
Okay. Okay.
Okay.
So, okay, good attempt. You picked up the finding. You had a good differential. You have to remember one thing in exam. So there are the things that have a typical presentation, like a very typical neurofibromatosis, very typical acute appendicitis. Those they show them 20% only in the exam, not more than that. But the common things with atypical presentation are more common, like they would be about 40 to 50%, I'm going to say, are those cases because they want to make it hard for you to see the common things. They're just the common things. And then some of them would be the rare things or the things that are not too important. Emergency is one of the biggest things that comes in this exam, one way or the other, and they show you a lot of these kind of cases. So I kept trying to tell you that the patient has lots of abdominal pain. So you see all this peritonitis here, inflammatory changes, see that? So why would
Yes.
the patient have these changes in right iliac fossa? It's a 23-year-old. What is the first thing, if you didn't see this, if you saw this, what would you think? First, the diagnosis.
Appendicitis.
Appendicitis, okay. So you
Yes.
would think that it
And
was appendicitis. Now you see that
yes.
there's an interception and you cannot make out the ileocecal junction here. There's no ileocecal junction here. There's no appendix here. All the colon is coming here together with the ileum, right? So
Hmm.
this and
Acute.
intersection of the ileocecal junction. Now,
Mm.
normally you're not going to have an appendix that is looking like this, right?
Hmm.
Acute appendicitis, you're going to see the appendix, but what kind of this is appendix, but what kind of appendix is this? It's a mucocele of the appendix,
It's a
basically.
mucosal. Okay.
Okay. So remember the common things first. You talked about Meckel's, but it never came to your mind that you could think about appendix as well.
Appendix, yes. Because I was assuming that structure to be appendix, and in my thought process, I thought it's normal.
Yeah, so you have to convey the thought process too if you think it's
Yeah.
a pending. And then it's causing, so for intersusception, all intersusceptions do not need surgery. You have to remember this. There are some that are
Okay.
transient. Those are the ones that are less than 3 centimeters. You see them and they go away the next time. Okay. This one,
Mm.
however, the patient has abdominal pain, there's inflammatory changes, and you see that there is a specific abnormality at the lead.
Hmm.
So this
Tubular
needs
structure.
surgical, so you have to say surgical
Blind
management
ended, yeah.
consult
Yeah.
because then they will decide. An important thing on any abdominal CT is that you are going to say that in your routine practice, you want the lung window
Hmm.
because you
For
want
new.
any perforation. Don't miss any abdominal CT you're looking at, especially if there's an obstruction, if there's anything. Always talk about lung window to see that you want to identify that there's no perforation. Always that. And the second thing is the vessels. Always try to look at the vessels. So these were the two important things in this one. Okay, very
Hmm.
good. Okay, so we'll go to the last, your last case now. Okay.
All right. This is chest X-ray frontal projection of a skeletally mature patient. Um, the bilateral lung volumes are preserved, and there is no patch of consolidation. However, I can see an opacity in the region of the right hemidiaphragm, a nodular area which is causing indentation, bulging of the right hemidiaphragm, and I, um, the cardiometastasis contours are within normal limits. Um, However, the humeral heads appears mild hypodense. The Now I'm looking at the visualized bones. Um, the vertebrae, some of the vertebrae are H-shaped. I would like to know the history of the patient.
Chest pain.
Okay, so there are some interstitial thickening and nodular opacity seen in the right lower zone. Um, this could be due to any infective inflammatory process. With the some of the vertebrae appears to be H-shaped, so I would like to know if there is any history of the sickle cell disease. If yes, then it could be an acute chest syndrome with possibly humeral infarcts and inflammation in the chest and yes, so on the lateral radiograph, I confirm my finding of the H-shaped vertebral bodies. I will talk to the referring clinician regarding this and will advise the workup and also the management for this acute chest syndrome.
The patient is known, so you still want workup?
Now, if it's a known patient, then the chest pain could be due to the infection of acute chest syndrome.
Okay, so when a person has an acute chest syndrome, what do you expect to see in that?
Um, Airspace disease
Okay.
changes
Mm-hmm. And
and no, the the cardiac size is mildly large due to the underlying disease. However, in acute syndrome, there are the lung changes due to the infection.
Mhm. So the this was just a spot film in which I wanted you to spot the sickle cell anemia, and you did, and it is a very basic film. So these are one of the easier films, but they are quite few. They show you these ones quite few. Mostly they are usually with complications. As soon as you spot that there is, you don't see a much abnormality in the lungs. Try to look at the other additional findings going to the edge of the film. Everyone should develop a technique, like I would start from here. Once I don't see anything in the lungs, I don't see anything here. So then I'd start from here and start to go like this to see
Mm.
that if I see anything like from here, like this, like this, like this, and going like this to see. And if you had started from here, you'd have spotted this at once, that the humeral
Mm.
head's funny. And then if you had come here, you'd have seen that the spine looks funny. So these
Mm.
are those films that you don't have much time, because they don't give much time to these ones. And in if you would say that maybe the patient has chest pain, so acute chest syndrome, so what and what could the patient have? So they could have pneumonia, they could have pulmonary infarction, fat embolism,
Yes.
or they could have rib or sternal infarcts, So since you didn't
Yeah.
see a cause here, you would say that you would tell the physician that this is a patient of probably known sickle cell anemia, and you would say that I would see the previous radiographs to make sure that this is a diagnosed patient, because definitely the patient is now 40 years, so he would be diagnosed by now. So you say that I don't see much here, but given that the patient has chest pain and background of sickle cell anemia, these are the things I would be like looking for. And if there's any further management needed, like sometimes the chest radiograph doesn't show the consolidation, but patient clinically has it and they can auscultate it. So then you can tell them, okay, if fine, if you want to, you have, depending upon clinical suspicion, we can investigate further. But not for every patient you are going to say workup, because if a patient already has the workup, you should not be advising the workup. So just need to be careful in advising additional things which are not needed. So overall, very good attempt. Your pick is good, and it's okay to not to see the abnormality. But once you see the abnormality, you can always retract your whatever you said before. One thing not to use is radio dense or these kind of things. Not to use those things which are not for a radiograph or not for CT. Like for example, using dense in MRI. So
Mm.
just be a little careful about the nomenclature. The examiners understand that you're under pressure. They understand you're under stress. So small mistakes, as long as you don't make a big blunder, you're good. You're doing really good. So well done.
Thank you, ma'am.
So I'll have the candidate two.
Assalamu alaikum, ma'am.
Welcome, Sam. See if you can control the screen. Try once. If you can, then I will show you.
Actually, ma'am, I'm on mobile, so I don't think I can.
Oh,
I'll be
no
able
problem.
to.
No problem. So it's your first case.
So this is an MR axial flare image of brain. Um, in which I can see fluid in mastoid ear cells and multiple hyperintense foci are noted in bilateral centrum semi-ovale. Um,
You can ignore those. Do you see any asymmetry? Okay, I have another image.
yes. Okay, so these are diffusion weighted images and flare images in which I can see um, a volume loss in the parietal region of the left cerebral hemisphere and hyperintense area focus is also appreciated in the parietal region of the on DWI and flare on both images. Hyperintense signals are seen in the parietal region of the left cerebral hemisphere. Okay, so ma'am, can I have more images or I have to give the diagnosis on these two images?
No, you can, but what are you thinking?
I'm thinking on the lines of infarct,
Okay, so I can show
as it is
you the.
giving diffusion restriction.
So, do you think that this is involving the cortex? Sorry, somebody is trying to move the mouse, I think. 1 minute. So, do you think that this abnormality is involving the cortex?
No, it is outside. It is extra parenchymal.
Okay, so what else? Which other images would you like to see here?
Um, can I see contrast enhanced images?
Yes.
Okay. So in these images, I can see that there is a contrast enhancement of the dural meninges
Mhm.
of the right parietal region,
Mhm.
and
Okay.
can you scroll a bit more?
Okay.
I cannot see any cerebral venous thrombosis in these images.
Okay.
Okay, so I can just appreciate the dural enhancement on these image.
Okay. So, what are you thinking?
I can think of any infective process,
Okay.
or there can be intracranial hypotension, or but this is only involving the left cerebral hemisphere, so it is something confined to. It is not a diffuse process.
Okay.
I cannot see any mass lesion or any other signs of infection in these images.
Mhm.
Um,
Okay. So, what are you thinking? I just need your diagnosis, your differential, and what you want. The patient is very sick. Again, an ICU patient, basically.
can these be? Is there any history of any malignancy or
Uh, so what are the possible causes of this? You said you see meningeal thickening. What are the possible causes of it?
ma'am, there can be intracranial hypotension, or there can be infection or meningeal carcinomatosis.
So tonsil is normal.
Yes, it is not intracranial hypotension.
Okay. So what else are you thinking about?
Has the patient got any history of fever or
Yeah, the
um,
patient is sick.
okay, so it can be uh, dural enhancement can be due to some infective process like is he immunocompromised too?
Uh, Not that I'm aware of.
Okay.
So just tell me your what you're thinking and what you think would be the next management.
Ma'am, I'm thinking that he's suffering from meningitis.
Okay.
Um,
Do
I
you see
will,
do you see a cause on these images? I told you he's not immunocompromised.
ma'am, there is a filling defect in the venous sinus.
Okay. Which venous sinus is that?
And in the left, this one, the left transverse sinus.
I think it's okay. It's okay. There are variations in them, so it's mostly it's you see this sigmoid sinus. It's mostly okay. It's just the way it's projecting.
Okay.
Hmm. Okay, so you don't see a cause on these images?
No, ma'am, I cannot appreciate.
So
There is some hyper intensity in the brainstem.
okay, so you can ignore that. So you think it's meningitis. What do you want to do next?
I will go for. I will ask the physician to do the LP for this,
Hmm.
and as there is no hydrocephalus, so LP can be done.
So you're going to tell the doctor that the patient has meningitis, right? So that they can
Yes.
manage this patient urgently. Like the patient is sick, right?
Yes.
Okay. So what are the causes, a differential diagnosis of meningeal enhancement? How else can you see it?
Ma'am, there can be tuberculous meningitis. It can be due to DVST. It can be due to some malignancy because of meningeal carcinomatosis, or it
Okay.
can be sarcoidosis.
Okay. So you have to say all these things. Like you got
Yes,
stuck.
yes, ma'am.
So the cause is on these images. So I showed you this because he has severe mastoid diffusion.
Ma'am, I appreciated mastoid effusion
So that
when I studied, but I could not
what,
relate it with dural
yeah.
enhancement.
So mastoiditis is causing his meningitis.
Okay, so just I just ignored it in the first image. I said also that I can see mastoid effusion, but I could not relate it with dural
Yeah.
enhancement.
So there are some important things in this particular scan which everyone needs to be really, really aware of. One is this flare sulcal hyperintensity. It
Hmm.
has a differential. So it could be infection like pus. It could be blood. Okay. With subarachnoid hemorrhage, you're going to see the same thing. So you have, if you see this, you have to give this diagnosis, and then you would say you would always want to do a post-contrast scan. And you would always want to look at the CT of this patient to make sure that did they see blood here, okay? So if you had asked me that you see this sulcal flare hyperintensity, do you have a CT? I would have given you the CT. So this is the CT, and here you don't see a blood, rather you see this kind of a fluid signal. See that?
Yes, ma'am.
So there is no hemorrhage. So hemorrhage we have excluded, but there's this sulcal hyperintensity. So I gave you the diffusion right from the beginning. But in exam, it might be that they just give you this and then you have to see between right and left. You started to talk about these things. These are those things they're not going to show you, these small dots
Hmm.
and foci in the brain. These are common. So try to
Yes.
ignore them and try to find the finding. Here you begin to see that there's something outside the brain. So everything that is bright on DWI is not an infarct. Always remember this.
So, ma'am,
Okay.
it was an abscess.
So yeah, this is all abscess, this is all pus, CS meningitis. When they did the CSF, it was frankly purulent, like there was pus.
Okay.
And so and then you come and then you see that you're going down and you see this. This is too much. Like and
Hmm.
then when I showed you the post contrast images, I kept scrolling and I kept staying here, hoping that you'd see that it's extending into the temporal lobe.
Yes,
So
ma'am.
there's also cerebritis. They
Okay, ma'am.
could, when you have these infective processes, you could have dural sinus thrombosis with it as a complication. You have to search for the cause. Sometimes it is just like sinusitis could be a cause. And here it was mastoiditis because he has severe kind of a severe mastoiditis. And then you see all this extension going into the temporal lobe. And it is asymmetric because these patients present really early, like he came early. So he does have some degree of meningeal enhancement as well. Like you don't see that many meninges here. So he has leptomeningeal, he has dural, and then you saw the flare hyperintensity. You know that there's something else sitting there except CSF, because on flare, if there's only CSF in the subarachnoid spaces, you're not supposed to see that appearance. See this?
Yes, ma'am.
There's something abnormal there. So this is a very, very important case for your practice, for your exam. It is an emerge. If you saw a normal, they had not done the post contrast, you only saw this and you read it off as a normal, that would be catastrophic for the patient. So this is very important to recognize. But you did well overall. Always remember, try to see the causes. If you see meningitis, it doesn't matter if it's asymmetric. Don't get worried because you're saying it's asymmetric. It could be early phase, it could be any phase. This patient, like I told you, is an early phase, and he does have more. And always remember that imaging doesn't show meningitis as much. Like the patient would have severe meningitis and imaging is going to show very mild enhancement. So don't get confused by the degree of enhancement. If it is asymmetric, it is not. So if you had not seen this and you had seen that there is meningitis, or you see asymmetric enhancement, so you say, I want to exclude blood. You want to exclude the patient. Did the patient was given like any contrast? Because if you do flare post contrast, you can also have this kind of thing there. And other causes are, of course, meningeal carcinomatosis, and the other thing is that you would say, is the patient known for a malignancy? Is the patient immunocompromised? And then if they said the patient does have malignancy, then you want to see spine imaging. Have they done spine imaging? Like, we ignored this and we think that this is all meningeal carcinomatosis. Then do we want to see, do we see a tumor in the brain, or does the patient have something in the spine? Or we want to image the spine as well. Okay. Okay,
Yes, ma'am.
good. So I go on to the next one. Anybody has questions? Okay, so if anybody has questions in any case, it is better to unmute yourself and ask right there, because once we go on to another case, we might kind of lose the thought about what it is or something like that, you know. So if I see some things in the chat, I'm just going to see what is written here. Who said, isn't it empyema? Okay, so what is the abnormality here? I missed it. I don't know which case this one is. And what is causing liver shadow being displaced inferiorly? So, and then somebody's asking, isn't it empyema? Can it be focal cerebritis? Yes, it was focal cerebritis. Empyema is when there is a collection. So when it forms a collection like a subdural empyema, it would be a collection. This is not a collection. This is in the subarachnoid space. You see the way it is. It's not forming, like, it's not forming an organized thing or a crescentic thing. If it increases, like if it had increased, if the patient had not been diagnosed, then he would have definitely developed a collection there, because it seems to be where it's focusing. Okay, so this is your second case. If there is, I don't know if you can unmute yourself and please ask the questions, because once we're gone from the case, then I don't see how. Okay, so the phrase about carcinomatosis and meningitis. Okay, so when you have meningeal carcinomatosis, sometimes the patient is diagnosed, but the patient is not always diagnosed. You need to remember that. So these patients present in different ways. Everywhere, it's the rule that the people who are who have less access to medical health facility, they may not be able to be like imaged from the beginning, and they usually come at an advanced stage, and that is when you're going to see the meningeal carcinomatosis. So meningeal carcinomatosis, where it is common from, you can see it from breast, you can see it from lung, you can see it from melanoma, you can see it from lymphoma. Like, anything can cause meningeal carcinomatosis. And what you would be seeing is that there is enhancement, and there is there may be nodules, and usually it may not be asymmetric, but don't always try to say that because it is asymmetric, so it can be. That's not the case. So I'm just going to see if I can pull up a case. I did have a case of meningeal carcinomatosis, but I didn't pull it up. Okay. Uh, okay, so I'm just going to pull up a case of meningeal carcinomatosis and show you. Just one second. So I just pulled up a case from Radiopedia, and so I can show this one so that we are clear. This is an important thing, by the way. So let me share again. And this is our friend Radiopedia. There are too many ads on this thing. It's very hard to study on this thing. Okay. So this is a case in which you can see this diffuse meningeal enhancement. It's a still image. 1 minute. Let me see if I can get a better image than this one. So this is the flare, and again you begin to see this thing here, right? See that thing there? Flare, and then here it is, and then you see this. So typically, the one that is caused by malignancy, they say it would be a little nodular, and you see the way it's here at the cerebellar folia, you see quite a bit. So this is meningeal carcinomatosis. There's no way to identify what is the cause of meningitis on imaging unless like there's a specific thing like this person, he had this specific really severe mastocytitis and we knew. And then, sorry, I want to show you one from the spine also. So let's open this one. Okay. So this is from breast, and you can see that there are masses and then there is enhancement. But it's not necessary to have only, you may not see this. The only thing you may see is this, I wonder if you can see it well, this thickening, this leptomeningeal thickening. That may be the only thing that you might see as well. So if you see nodules, you become more confident that it could be either METs or it could be a granulomatous process as well. So even this is with nodules. So I wanted to see one in which there wasn't, let's see, what is this? Okay, let's see this one. So this is, they say extensive leptomeningeal seeding, and then you can see here that it is more kind of a meningeal thickening, and even you see it in the brain. So this is meningeal carcinomatosis. I hope I've answered the question. If there's anything still left, please let me know, and I can clarify the question again. Differentials for this case. Okay, so the thing is that you saw the flare hyperintensity. So when you see flare hyperintensity, there are very, very definite causes of that flare hyperintensity. You have to be really careful that you pick it up. So number one is meningitis, of course. Before meningitis, subarachnoid hemorrhage. Please keep in mind subarachnoid hemorrhage. Always say that if there's a CT, I can see the CT. That would be the number one cause. They might say, no, there's no hemorrhage. And then you know that they don't want to talk about hemorrhage, something else. So don't try to insist when they're trying to guide you about something. So meningitis is the case we just saw. Then meningeal carcinomatosis, we also saw a case. Then melanoma can also do it. And then fat-containing tumors, when there's a ruptured dermoid, you may also see something like this. They also say that you see it in stroke, okay? You could also see it in stroke and with contrast media also. So these are the causes. And then another one is oxygen. So sometimes patients who have been given like high flow oxygen and they have this, you could also have this flare hyperintensity. But say that at the end, because I don't think for the level of this exam, they're going to be showing something about oxygen. It's not, it's going to be something else. Okay, well, about sickle cell case, liver was inferiorly displaced. I don't think it was much about it. After we finish this case, I'll go back to the sickle cell case. Um, I don't really think the liver was inferiorly displaced or something like that. Like that would indicate something. The spleen was atrophic in that patient. However, and it was not well seen even on ultrasound, not an X-ray. So whenever you're looking at a sickle cell patient, you try to see his gallstones, you try to see the H-shaped vertebrae, you try to see the avian of the humeral head, and always try to see whether you can make out the splenic shadow or not. Because when the splenic shadow is not there, then it has this, now here the spleen is there. So that's why you see the colon here. But you might see something calcification here, which will lead you and say that this is that. So that's it. Okay, sickle cell exam, ma'am, liver is displaced. Okay, okay. Oh. Okay, so we will go to the sickle cell afterwards. So I also want to see, because I'm getting a bit confused. I can't remember that I saw the liver displaced, but I will surely try to see. Okay. So let's go on to your second case now. This is your second patient.
Okay, ma'am, this is a chest X-ray frontal projection of an adult female patient in which I can see there is a paraspinal radio opacity along the DV 10, 11, and 12 vertebral bodies, and this is likely a posterior mediastinal mass, and rest of the lung fields and the visualized bones and upper abdominal structures appear unremarkable. On the lateral chest X-ray, um, dear, lateral chest X-ray pe.
You don't see the abnormality.
Yes, ma'am.
Okay, no problem. Okay, so what are your differentials and diagnosis, and what do you want to do?
Ma'am, on the frontal chest X-ray, I was just thinking about all the differentials of the posterior mediastinal masses, like if there although I can see all the bones are normal in density in their I cannot see any osteopenia or any coarse trabecular pattern to say that these are extramedullary hematopoiesis, or there is no vertebral irregularity to suggest that this is a paraspinal abscess, or it can be in the posterior mediastinal masses, it can be a foregut duplication cyst. Um,
So what stripe is this?
Paraspinal,
It is
para,
the it is the right paravertebral stripe.
paravertebral, yeah, ma'am,
Right
paravertebral.
paravertebral stripe is elevated from T9 to T11,
Yes,
right?
ma'am.
And you said you don't see calcification. I'm just repeating these things because this is also an important film. Some of the things you said were really nice. So you don't see a fracture here because it could be a hematoma.
Yes, ma'am.
You said that you didn't think that it was an abscess.
Mm. Yes,
You
ma'am.
can you cannot rule that out. Okay.
Yes, ma'am.
So then you said it could be a posterior mediastinal mass. Good. And then you said the lungs are clear. So that's it. So what do you want to do next?
Ma'am, on the lateral chest X-ray, I cannot see anything, so I will go for CT.
Okay.
Okay, so on CT scan plane examination, I can see a hypodense collection or a soft tissue density along the right paravertebral region, which is causing erosion of the vertebral body.
Okay.
I
I'm just
want
going to.
to, yes, ma'am, I want to see the bone window for this. I cannot see any calcification or any, yeah. So this can be so this is causing erosion of the vertebral body, adjacent vertebral body. So there is no connection with the, yeah, communication with the neural foramen. So this is likely an infective process. In our um, community, my first differential would include tuberculosis, as the intervertebral disc spaces are normal, and this
Mhm.
abnormality is eroding the vertebral body. So
Okay.
my first differential would include tuberculosis, tuberculous
Okay.
spine with paravertebral abscess.
Okay. So what
Um,
is your management? What do you want to do next?
okay, so I would do the gene expert for this. Okay, no, right. So, okay, so confirming my findings on MRI, I can see that there is abnormal signals in. Okay, so where has it? Ma'am, can you scroll a bit more? Okay, so I can see a peripherally enhancing collection along the right paravertebral region of the D9 and D10 vertebral bodies, and there are subtle. Uh, I cannot appreciate the rib erosion. I can see edema. Yeah, there is rib erosions also, confirming my findings of the tuberculous spine along with right paravertebral abscess.
Okay, so next, what's your management?
Ma'am, I'll inform the primary physician for this, and they will start the ATT, the
Uh,
chemotherapy.
is there something you should be doing before you do that?
I will image the
So,
I'll go for the chest X-ray to see if there is any tuberculosis, pulmonary tuberculosis. I have seen it before, so there was no pulmonary tuberculosis. The
mhm,
chest were clear.
okay, so
On the lung window, the lungs appear normal. There is no
okay.
evidence of pulmonary tuberculosis.
So what's your management, which is the most important thing?
To drain this abscess, drain this abscess, and to start the ATT of the
Okay.
patient.
Okay, so you did this case well, but from management point of view, I would say you need a little improvement. Management point of view for TB, for exam purpose, everybody has to be aware of what are the guidelines.
Yes, ma'am.
First of all, to isolate the patient.
Okay,
Okay.
ma'am.
Second thing, you don't know if the patient has pulmonary tuberculosis or not, right? You don't know. Like you are just looking at the patient. So when you said on this first thing, that the patient has, sorry, on the CT that you think that the patient has tuberculosis, which is a very good diagnosis, then you would have started to say that you are going to isolate the patient. You need to do contact tracing. And the third thing is that you're going to start the investigations for tuberculosis, all of them, right?
Yes,
And
ma'am.
then you get interventional radiology involved because you want to obviously brain this collection. And then you have to look for multifocal involvement and you have to rule out intraspinal extension. If you don't say these 5 things in this case, you may not
Mm.
pass the test. So you
Okay.
said that there was not intraspinal extension, but look at this.
On MRI, there is evident. Yes, ma'am.
So you have to be really, really careful. Think like if person has, for example, anything that is close to the spine, you are afraid that is there intraspinal extension or not, because that changes the management completely. If there is
Yes, ma'am.
intraspinal of anything, be it cancer, be it this like fluid collection or abscess, then your management changes completely. So this is a simple case, relatively simple case, but why they're showing you simple cases, they only want to see what is your approach and how you are going to manage this patient. That is what they're looking at. And anybody who doesn't say that you're going to isolate it, you're going to do contact tracing, fails the case. That
Okay,
is
ma'am.
like Canadian exams, it is the rule here must, because there are lots of immigrants here, and whenever they find tuberculosis, they isolate the patient at once, like ASAP.
Yes, ma'am.
So yeah, so this is this. So we'll label this patient a paraspinal abscess. Yes, this is a paraspinal abscess. So when you are describing X-rays, you have to leave room for yourself. Don't try to exclude things too much. So get rid of the X-ray. Always remember in these exams, you have to get rid of the X-ray because that is, for some cases, yes, like for the sickle cell, the X-ray is diagnostic and we see this, but this is not diagnostic. The next thing is going to be coming. So here you would say that the right paravertebral stripe is displaced. Try to use the terms that are supposed to be used. So in this, the right paravertebral stripe is the important thing here, because it doesn't look like a mass here. It could be a mass, but it doesn't, because when you see posterior mediastinal masses, they're usually round or oval, or they have a kind of a different appearance. So at this point, usually when you see something, either it's trauma and it's a hematoma, and you don't see the fracture here, you always keep that in mind. Or it could be that you have a collection, which this one was, and you didn't see vertebral body destruction, but there was vertebral body destruction, right? So this CT was done first. This is 18th May. This X-ray was done afterwards. So
Okay.
there was bony destruction, but we don't see the bony destruction. Okay.
Yes.
If somebody is really careful and we go retrospective, maybe it was like this part. See this?
Yeah, the first.
Yeah.
First.
But you can't be sure. You can't be sure. Okay. So you have to be really living in a, and then you said a very, very nice thing, which I liked a lot, is that you at once thought about extramedullary hematopoiesis. You told me that the bones look normal, and you're not thinking that it's extramedullary hematopoiesis, which is a very good negative point. So that is how you have to treat. So think about these paravertebral things and what are going to be the 3 or 4 major things. So of course, a tumor, you would put it in. Collection abscess, you would put it in. Extramedullary hematopoiesis, you would put it in. And hematoma, you would put it in. So these are the 4 things we do. So isolation you need to do for patients. Somebody asked me what are the things. So you need to say the first thing is you're going to isolate the patient, number 1. Then you need to start contact tracing. So the public health has to be informed immediately, and they immediately get the family, the people who work with that patient. And then you start the workup for the tuberculosis, and you get IR consult. And then you always have to rule out that it may not be the only thing present. Always think that could be multifocal. So preserving the disc, and then the subligamentous spread, that is typical of tuberculosis. Pyogenic, it is going to destroy the disc very quickly. So in spite of that, there's so much disease, you see the intervertebral discs or spaces are relatively preserved. And then they did the whole spine here because they want to make sure that there's nothing else in the spine elsewhere, because CT is not a good modality. It may not show everything. So so you really need to make sure that you image the entire spine to rule out other, because then in the lumbar region, you know that the psoas abscesses are very common, right? So you need to rule that out. Is there any other involvement? Sorry, any other question? So disc involvement, I'm not sure. Probably there might be, but even on these images, to say whether there is or there's not is a bit difficult, because the discs above and below appear similar. Here, they look, maybe they're a bit edematous, but it's mostly subligamentous spread of the infection. Any other question? Can we go on? So we'll go to your third case then. Do you have any question?
No, ma'am.
Okay,
We
good.
just have to correlate all the things, as on the CT I could not see the intraspinal extension, but I should have reviewed it in the MRI too. That's my learning point.
Yeah, okay. So this patient comes to emergency and has abdominal pain. So
Okay.
I can start to scroll for you. Uh, I would ignore the liver things, okay? Just for the sake of time, we can ignore the liver things. I'll talk about them in a little while, but we can ignore them. So of course
Okay.
they're not related right now to this patient's presentation.
So these are axial and coronal CT contrast enhanced images in which of the abdomen. Okay. So in which I can see dilatation of the small bowel loops,
Mm-hmm.
and I can see nematosis in the walls of the bowel loops.
I think this is just air. So if you see the way, if you follow it, see,
Okay, okay, okay.
Doesn't look like dermatosis. Just air everywhere, like just fluid and
Okay.
air filled bowel loops. Yeah.
So these are dilated, fluid, and air-filled small bowel loops. Um,
Okay.
okay, so can I see the coronal images?
Yeah.
I can see the radio dense. Um, hey, ma'am, can you scroll then so that I can? On the coronal, I could see a radio density within the, yeah, no, not this, in the middle bowel loops, ma'am.
Okay. This one.
Yes, this one.
Okay. I think I would ignore it. It's not.
Okay,
So how can you ignore it? Because it's very proximally present, but the bowel dilatation extends beyond that, isn't it?
yes, ma'am.
So, okay. So,
I cannot see the transition. I cannot make out the transition point.
okay. So I just want to give you a description before I say anything. So just describe it and just tell me what you want to do next.
Okay, so I want to see the lung window too, to see any perforation or any. I cannot see any free air
Okay.
outside the bowel loops to suggest that there is any perforation.
Okay.
So the patient came in emergency.
Yeah. Severe
So
abdominal pain.
I can see the sore.
So I want you to, whether you do know the case or you not know the case, you have to go on. You have to complete your description and then come to it, and then we can go on from there. So I want you to
Yes, ma'am.
describe.
So I want to see the appendix as it is the cause of one of the emergency. Um, so the appendix appears to be fine.
Okay. Here.
Yes, ma'am, it's fine. So there is any. I can see.
So can you summarize?
I can just see the distended. I can see the small bowel obstruction is there,
Mm.
but I cannot make out the reason or the lead point. What is the reason for this small bowel obstruction?
Okay.
I can see multiple
But
vaginal loops,
what are the possible causes?
and there can be any mass, there can be any interception,
Mm.
or there can be. Um,
So next, what's your management?
Ma'am, I have to rule out on these images only, but
Okay. So
I'm
just
not.
management, and then we can go on.
I can see air in the rectum, so um,
Okay.
ma'am, I am going to see the. Can you scroll on sagittal images again, please?
Yes.
I cannot see any lymphadenopathy, abnormal lymphadenopathy, or free fluid over here.
Okay. Just tell me your management, and we can go on.
I cannot diagnose, so I cannot tell about the management
The
too.
patient is, you see that the bowel is dilated. So what do you want to do?
I will go for an ultrasound, but not no
Where will you refer the patient?
to the gastroenterology team.
Maybe you think the surgical team?
Yeah, the surgical team. Yes, ma'am.
Yeah, the bowel is dilated, right?
Yes,
So,
ma'am. The bowel is
okay.
dilated.
Okay, so this is one of the cases that is not so uncommon in the emerge. So you see the bowel dilatation, the bowel obstruction is there, the patient is sick, the patient is very sick, the patient has severe abdominal pain. So the most important thing to see when you see bowel obstruction, I'm going to give you some points. First of all, establish, do you see a transition point? Okay, always try to look for that transition point. Once you have established it, look on the lung window for air. Even if there is less time, they're going to say there's no air, free air, and then they, because they don't want to show you the lung window. Okay. Third thing is look at the vessels, mesenteric vessels. Is there a mesenteric vessel thrombosis? Okay. So if it is a mechanical obstruction, you determine that it's a mechanical obstruction, then you need to look what is the cause of that obstruction. So if you don't see any, then the things to suggest is if the patient has had a previous surgery, it could be adhesions. There could be a mass there. Okay.
Yes, ma'am.
So then you need to look for all those causes. In this case, there is no transition point. I want you to follow. I'm going to go through this with you. So you see the dilated bowel is coming. It is coming, and then it just comes like this. See, just
Is this a
normal.
volume swirling of vessels?
No, no. It is
Okay.
just. It is coming because it's not obstructed. There's no obstruction here.
Yes, ma'am. I could not see any transition.
So you said there's no transition point. I agree there's no transition point. So there's no transition point. The surgeon looked at this patient and you see the normal bowel loops here. So this
Yes.
is then what? This is an ileus, right? When there's an ileus, what is
Okay.
the
Yes.
cause of ileus? Maybe the patient has had a recent surgery and it could have had post-operative ileus because you see all these changes in the abdominal cavity, number one. Number
Yes.
two, does the patient have pancreatitis, appendicitis, cholecystitis, anything? So then you need to look at the gallbladder, you need to look at the pancreas. Any acute inflammation in the abdomen can give you an ileus appendix. Everything is normal. This is a
Mm.
female patient. I kept showing you this, but you didn't even come towards this. This is calcification. This is fat,
Okay. So this was a dermoid.
dermoid. And but what is this here? What is this here?
The ruptured dermoid.
It is a ruptured dermoid. See this
Okay.
fat here? See this
Yes,
fat?
ma'am. Yes, ma'am.
So this was a ruptured dermoid causing the patient. See this fat here?
Yes, ma'am.
So in acute abdomen, you have to be really very, very conscious of what you're looking at, how you can see it. Even if you had seen this, that the dermoid is there, you didn't even try to diagnose it. I showed you the coronal image because I wanted you to see that the rectum is here. So you can make out that this is the rectosigmoid. You can make out the rectosigmoid here. And you know that this is an obvious pelvic mass. You didn't even try to comment on it. Then
Yes,
why should you see this? Then why should you see all this fat here? So there is diffuse like rupture and there's fat all over, and this is what is causing this ileus. And the patient had severe abdominal pain. They had to take the patient straight away to surgery.
ma'am. Okay.
So these are the hints for you to look when you're looking at things, how to manage things, decide mechanical bowel obstruction and what is the cause? Or is it there's no transition point, then it's an ileus. Then if it's an ileus, then try to search for the cause. Don't forget the free air, don't forget the vessels, okay? Don't forget to look for masses. These are would be the main things here. But this patient was really, really like sick. So yeah, this is a chemical peritonitis case. Exactly. It is. It is. So okay. So my dear, you did well. I so the most of your findings, like you picked on the cases, you picked the findings, and then you need to work a little bit on looking at the causes of things, and but otherwise you did really well. So very good.
Thank you, ma'am.
So I'll have candidate 3, I think. What is in the liver? Okay, liver. Yeah. Okay. So this liver, I'm just going to see, I'm just going to tell you in a minute what it is. 1 minute. Okay. Okay, so the liver is a combination of cysts and hemangioma. So for the liver, change it to liver window. Here I change it to liver window. So as soon as you change it to liver window, you begin to see the cysts. If you have any doubt ever, then just say that you would look at this. But this is very close to this. So then you know that this is a cyst, this is a cyst, this is a cyst. This is not a cyst, this one, right? This is not a cyst. But and then you would say that you see something that doesn't look like a cyst, and you would call it indeterminate because you can't really characterize it on this single phase study. You cannot say what it is. However, you could say that in the absence of known malignancy, it could be benign. I would confirm with an ultrasound, and I think this patient did have an so in 2013 she had a CT. I will try to load this if it can come. Uh, so this was known as a hemangioma. So this was known as a hemangioma. And otherwise, most of them were cysts. So that's why I told you from the beginning not to concentrate on the CT because this was a very nice case. I didn't want to yeah. So this is the dermoid here. This is the dermoid. So you have to be careful because it's not a bowel. Like you can see the fat here and you can see the fat here. So be on the lookout for fat. We tend to ignore it. This is fat, this is soft tissue, and then you saw the calcification. This is the calcification. And then you begin to see, once you see this, then you begin to see this, you begin to see this. So once you have seen something, like you told me that the bowel is dilated, then you have to try to look for other things. So there's fat everywhere in the peritoneal cavity. Same as a ruptured dermoid, they show you intracranially, which they still show actually. So this is also, here also you see that that's fat, see that? So there was no air, but there was fat. Okay, so this is all fat. So this is this, and then this patient here, I didn't show you this one because here the patient had really worsened. And so you might have been, no, I think this was the, yeah, here you can see it even here. So there's been redistribution here and there is this fat everywhere. See that? Okay. So there is a CT from 2013. Let's look at this one. So this hemangioma was there then. So 2013 till now, it can't be anything malignant. And where was the dermoid? Here, I'm trying to see. So that's her uterus. Okay, so this is the dermoid here. See the dermoid here? Sorry, this is Siri trying to get active. Okay. So see the dermoid here? So the dermoid's been there for quite a bit. Okay. Okay, so any other question with regards to acute abdomen? Does anyone have any question for it? Because that is one thing that we really need to be, we should know how to manage it. Okay, it's okay if you don't know the diagnosis every time. It doesn't mean that you're going to fail it, but as long as you can tell them transition points, you can tell them it's ileus, you can tell them it's mechanical obstruction, I don't see the cause, but this is what I'm going to be doing. As long as you tell them a very good management plan, do not stop. If you think you do not know the case, do not stop on it. Keep going. Whatever abnormality you have picked up, try to tell them logical things because it looks like an ileus or obstruction. No, every acute abdomen does not have a surgical management. No, but the surgeon has to assess every acute abdomen because they are going to be the ones that are going to decide whether this patient needs surgical management or not. Okay. So they will clear the abdomen. When the surgeon sees it, they'll say, no, this is not a surgical abdomen. This was a surgical abdomen because it's not, it's ileus, but there's a ruptured dermoid. So they had to remove that surgically. Okay, so someone is saying that, can you please briefly tell small and large bowel obstruction, many points in nutshell? Okay, So basically is that whenever you have a bowel obstruction, if you can see the scout image, it is very, very helpful. I'm going to go back to that case. I didn't see the scout, but I'm thinking that I should look at it. Let me see, what was the name of that patient? Okay, Dubey. Here. So this is the scout of the patient. Okay. So this is the colon, and this is the small bowel. So the scout doesn't help us much in this case. But usually what happens is that whenever you are looking at a case in your routine practice, okay, here you can see the small bowel obstruction really well. See, you know that there's, sorry, small bowel dilatation, not obstruction. So here you can see this small bowel dilatation really well. So what happens is that, first of all, decide, is it small bowel? Is it large bowel? Is it both? Okay. If you see small and large bowel both, then try to go down the large bowel, because it might be an obstructing like carcinoma. Sigmoid cancer really presents with bowel dilatation all the way up, and you might see liver mets in that case as well. So then you would see that. Other causes of large bowel obstruction could be like some diverticular disease or some diverticular strictures or things related to diverticulitis. It might be related to like radiation if the patient has prostate CA and then bowel obstruction because of that. So these would be some of the points that you could see with regards to large bowel obstruction. Then one very important thing to see in the elderly people is the abdomen is the small and large bowel loops are dilated. There's no transition point and there's no cause. So that is the pseudo obstruction or algivis. Okay. So that would be that. And then the other thing that for small bowel, you try to see where it is does the patient have an internal hernia? Number one. Is it mesenteric ischemia associated? Is there ischemia associated with this small bowel obstruction? Do you see the superior mesenteric artery and vein very well? Is the appendix, is there any problem in the appendix? Is there any inflammation in the abdomen? So these are the general points you would see. And then what else would there be? And then of course you want to see the lung window for that. So suppose we see an obstruction and we can't understand what's the cause of that obstruction. So I would say that you always should get surgical consult, let the surgeon see, let them, they know really well. Sometimes they don't know, but really they would know. And if it is a mechanical obstruction, you know that it has to be relieved. Even if it's cancer, you cannot say to a mechanical obstruction with this, for example, a sigmoid cancer with mechanical obstruction and METs. So if you started to say that you're going to start workup for the METs, you're going to do a staging chest, you fail, because you have to relieve that obstruction. If the patient has an obstruction and that cancer perforates, then you have given the patient stage 4 disease. Okay. So now what we're going to be doing is that for that patient, you have to relieve the obstruction first. So if you see something acute, for example, you see there's hydrocephalus, severe hydrocephalus, and there's brain like mets, you're not going to say you're going to do the staging chest. No, you have to get urgent neurosurgical consult. You have to relieve that hydrocephalus, and then you're going to go on to work further for other things. So always think what is going to kill the patient. Okay, what is the emergency in this case? What is needed right now? So those are the questions I would say that we really need to concentrate on when doing it. I hope I answered the question. If there's still something, please let me know. Otherwise, we can go on to the next one. Okay, so I'm going to go on to the next one. Okay, candidate 3, I believe.
Yes, ma'am, I'm here.
Okay. So we're going to be going a little over time, I think, because in addition to the oral thing, we are doing a little bit of talking. So we're going to be going a little over time, but I have cases for 4 candidates, so we can try to finish. I don't have problem, it's Sunday, but I don't know about the candidates. So just let me know if I need to stop, but if we are okay to continue, then I'll continue. Okay, so CT head for you. This is a 55-year-old.
Should I take control or you will scroll for me?
Yeah, you can, if you can, please take control, try it. I don't know, this Zoom, it is funny because it doesn't,
ACT brain axial section. Showing no gross abnormality. However, there is a hyperdensity noted along the right transverse sinus and scrolling. And there is a defect also in the right petrous bone with soft tissue density opacification. Mm, I cannot see any other gross abnormality. The cisterns and ventricular chain appear unremarkable. Bilateral mastoid hair cells are also unremarkable, except for that destruction of the petrous bone. There is no mastoiditis. There is subtle hypodensity of the pons as
you
well,
can,
but that
you can,
can be okay. I
yeah.
can ignore. So there is a destructive process. I would like to go for MR on the CT. It could be some schwannoma or metastases or some.
Yeah. So I will give you the next set of images and you can request. So they did this. They did a post-contrast study when they saw that.
There is non-opacification of right transverse sinus, likely representing thrombosis of the right transverse sinus. And can I change the window, the bone window, or I?
Okay, 1 minute. Let me
Oh, I
bring the
saw. I mean brain window or a
bone
bone
window.
window, bone and brain window.
So there was nothing in the Peters FX. That you saw was just artifactual. So if you see something,
Okay.
then you would confirm it on the, what do you call it, on the bone window, because
Yes.
things could be artificial.
Okay.
So, okay, and you want to see the brain window here? Here.
Yeah. I could just appreciate this hyperdensity in right posterior fossa along right side.
Okay, so what's your diagnosis and differential?
My first diagnosis would be the transverse sinus thrombosis. It can be any other lesion like extraaxial lesion, uh, meningioma, but that shows homogeneous enhancement. That is the but
Okay. Uh, so what, so what's your diagnosis in this? Do you look at the coronal image that is down below?
no. Here I can see non-opacification of the right transverse sinus
So
and
what's
right
your
sigmoid.
and management?
So it's right transverse sinus thrombosis.
Mhm.
Management would be I would alert the referring physician and ask for the D-dimer levels and further thrombolysis.
Okay. And what else?
I would also want to do the MR of this patient to see any infarct in the adjacent brain parenchyma, as posterior fossa is not better visualized on CT.
Okay. So this is the. So basically on
There is
this.
no restricted diffusion seen in this.
Mhm. So this is the susceptibility weighted image, and you see this.
Yes.
This is the normal one. So you see
Mhm.
this. Okay.
There is blooming artifact of the right transverse sinus.
Yeah. And what else do you want to do with respect to management now?
What else? But I cannot see any cause except this hypointense signal.
Exactly. Exactly. So you want to see the cause. So you have to
Yeah.
be in your discussion. Also, dural sinus thrombosis is something that you should, even if somebody asks you in your sleep, you have to talk about it, because this is one of the key cases they are going to talk about in the, like there is always one way or the other, they want to show you dural sinus thrombosis. They are very
Okay.
obsessed with it, okay? Especially FRCR exam. So you have to talk about the risk factors. In female patients, you could be thinking that it could be oral contraceptive. Well, if you don't know
So
the age of
severe post-cesarean, postnatal.
yeah, pregnancy, perperium, then the prothrombotic conditions you have to always talk about, and always look at the local factors. So that's why I was showing you this MRI head. I wanted you to comment on the mastoids, and you comment that everything here looks okay. You
Hmm.
don't see in the sinuses, nothing in the mastoids, nothing local going on there. So
Yeah.
that is why the MR was done to rule out a cause there, and then trauma is one cause. So you always need to exclude, look at the bone window when you see something like this, to see two things. One is that, is there anything going on the mastoids? Is there is fracture here that could have caused it? Okay.
Okay.
Then the dural sinus thrombosis, it presents in two or three ways. Okay. One is the obvious, you have the hemorrhage, and then you know that the hemorrhage doesn't conform to an arterial territory. So when it's an arterial territory, you're going to see it in the MCA, like involving the basal ganglia, frontotemporal lobes, and then you know that, okay, this is MCA. ACA, you know where the ACA is, bilateral anterior lobes, and PCAs, you know, you're going to see it in the occipital lobes. So once you see that there's a hemorrhage or there's an infarct that doesn't conform to these territories, now you're going to start thinking about dural sinus thrombosis. Could this be a cause of dural sinus thrombosis? Okay. So then you look at the clues of it. So sometimes the clot in it, depending upon your hematocrit, always remember that hemorrhage is something that is very difficult at every stage. Like I've been practicing for more than 15 years and I still miss it. I still miss it. I'm just telling you. So it's nothing, it's not that you just have to be vigilant, is that either now this example here, so what was it? It is looking dense here, right?
Hmm.
And it could, you could have thought that maybe it's trauma. There's blood in the tentorial leaf. That could also be a cause there, right? But then you follow and then you see that the sigmoid sinus looks abnormal. So then you know that this is, maybe this is something else. So sometimes it is the increased density, sometimes it is the low density. So there are other cases, if you will Google, you will see that it looks as if there is something within the sinus. It won't look like this. It will look as if there is a hypodensity within the sinus. That is also a presentation of it. You could have a hemorrhage, you could have a hemorrhagic infarct, okay? And then on the post-contrast images, you're going to have the empty delta sign, in which I don't have it here. But what happens is that you could have, in which there's a filling defect within the kind of sinus. Here, what you see is it's completely gone. It's completely non-opacified here, right?
Hmm.
So it's completely thrombosed, like it's a big thrombosis here. Those are all the things is that you have to be able to recognize the empty delta sign. You have to be able to see the prominent perimedullary veins which are there when this is present. And then I have a follow-up for you. So they did a follow-up, and this is the follow-up. So here you see that.
Mm.
So it has
It's
started
not
to realize, right?
recanalization, yes.
Yeah. So this patient had a prothrombotic condition, and this is how he was diagnosed. They didn't know it before, and he presented like this. He presented with severe headache. And the first CT that was done for this patient, it was missed. So on the first CT, I'm going to bring that up here. I think it's this one. It was missed on this CT. Then this was 19th October. So they said the CT head is normal. Okay, here. Then 20th October, the patient came again. And the patient had such severe symptoms that they said maybe the patient has a stroke. So then they did the CT angiogram basically here. So then on the angiogram, whenever you're reporting an angiogram, you have to look at the venous structures. It's not that you're going to have a venogram. Okay. So this is the sigmoid sinus here, normally opacified, and the transverse sinus, and then you see it coming here to the confluence of the sinuses. Here there is non-opacification. See that?
Mm.
See? So that was the transverse sinus, and this is the sigmoid sinus.
Sigmoid sinus.
And this is the internal jugular vein here forming. See that? And look at it here. So then you need to trace it down, and you see it's going down. It's going down. It begins to come up here, maybe a little bit, but here, and here you see it normal. This is it here, and then here there's no internal jugular vein. See this? So it is extending into the internal jugular vein, and this is it. So very, very important that you assume that you're going to be given a dural sinus thrombosis. You have to search for it. If you see bilateral thalamic, like low attenuation on a CT, always remember that it is very common to have the internal cerebral vein thrombosis, and then you would have like the thalami would be swollen and edematous because of bilateral thalamic involvement. Okay, so that is also one very favorite exam scenario. I don't have that case, but I've been shown once in exam in which the internal cerebral veins were thrombosed and there was edema in both thalami. If you see that low attenuation of thalami, there are three main causes you need to think about: neural sinus thrombosis, artery of Percheron infarction, in which there's a single artery which is supplying both thalami, and then so when that you can Google this, you will see it on Google, this one, and I've reported one case sometime. So then you'll see both thalami would be infarcted, and the third would be like thalamic gliomas. So you can also have that bilateral thalamic gliomas, or I have seen one case of that as well. So these would be the causes. This is just in the context of the dural sinus thrombosis discussion. Is there any question in this case? Okay, so I'll go on to your next case.
Yes, ma'am. Sorry.
So patient presented with severe back pain. So follow-up is the clinician does it, but yes, encephalitis can also cause thalamic enlargement, edema. Any infection can cause it. So follow-up is typically they do it really quickly. So like 2 to 3 days, they would see if there's any worsening, if the patient is developing. The plain CT head, they usually do every second day. Sometimes if the patient is very sick, every day. And the post-contrast one, they would do at least 2 in 1 week, and then the follow. If they see it is improving, patient is clinically improving, then they can take it to like 2 weeks, something like that. So this is it. So this patient is 22-year-old male, and he's presented with severe back pain. Also came to the emerge.
Okay, I'm provided with MRI, thoracic spine, sagittal sections T1 and T2 showing altered MR signal intensity, extra axial lesion posterior to the, I think, D4-5 vertebral bodies, and it is compressing the cord anteriorly. There is also altered MR signal in the adjacent vertebral body and the posterior aspect as well in the lamina and the pedicle. I think I would confirm on axial section that there are
Okay.
some T1 hyper and hypointensities in the extraaxial lesion within the spinal canal. On T2,
This is the stir image.
sorry, star images, I can see um, this altered MR signal. This lesion is extending outside the vertebral body posteriorly, and it is causing marked compression of the spinal cord with hyperintensity to stir signal within the cord in this level and also above. And hyperintense stir signal also noted in the vertebral body, which were
Okay.
high on T1 weighted images.
Okay. I'm just going to take the sorry for a minute. I want to
Yeah.
give you the axial image. So this is the axial image for you.
Yes. On the axial section, it's not scrolling.
Sorry. Yeah. Okay.
Oh, yeah. There is a hyperintense signal on in the vertebral body and the pedicle and posteriorly as well, and this is causing. I cannot see any extension or erosion of the vertebral bodies in the spinous process. So, and mm, this posterior. So, I would like to give two differentials. One could be the hemangioma, vertebral body, as well as within the spinal canal, or it can be some arteriovenous malformation with the.
So what is all this like? Let me show you 1 minute. So you see this, you see this, you see this, because this is the cord, right? Sorry, let me
Yes,
take the
cord
mouse.
is markedly compressed anteriorly, and it's surgical.
And
It's I would alert the neurosurgeon,
yeah,
because it's an emergency.
okay. And this is the post-contrast image. So I'll scroll that for you.
Hmm.
Okay. So okay. So diagnosis, differential management.
Diagnosis can be mm, mm, I think it's a extraaxial hemangioma or less likely any neoplastic lesion, but that's less on the differential list, and could be an AV fistula with hemorrhage or infarct causing the vertebral body and the spinous process and the lateral transfer process. And
Mhm.
from the management point of view, I would urgently contact the referring physician because it is causing marked compression of the spinal cord anteriorly with hyperintensity to signals and star signal, and it should be urgently operate and do decompression to relieve the spinal cord.
Okay. So what is the your diagnosis is absolutely very nice. It is a hemangioma, but what kind of hemangioma is this?
Mm,
There's a name for it.
I can't remember the name exactly, but uh,
So this
the
is
vertebral,
an aggressive
yeah,
vertebral
aggressive.
hemangioma. Okay.
Mm,
There are certain points in this which I'm going to go over quickly. So what it causes is that it causes vertebral expansion, and then there is epidural extension, which we see in this case. There can be a compression fracture associated with it. There could be spinal cord and nerve root compression because here you see the way it's extending in. So obviously the nerve root is going to be compressed here.
mm,
And then it has an extra osseous component as well. So the most important point is see this corduroy pattern here.
yes.
See this? So this is the corduroy pattern which you typically see with hemangiomas. And when you see this, then you say that this is a hemangioma, but it is an aggressive hemangioma because of the extension into the spinal canal and the way it is narrowing this thoracic cord. So to prevent the patient from permanent disability, because the patient could be paralyzed. So actually there is some signal which you didn't comment upon. So that was the only thing I wanted to show you. Otherwise, you took this case really well. So there is signal already in the cord. So that means this patient would call it cord myelopathy, and
Myelopathy has been
it could just
mentioned.
be edema. It could be already infarct in the cord from this compression. But the most important thing for spinal cord things, especially when there's narrowing, is to look at the spinal cord and to say whether you see a signal abnormality in the cord or not. And the other thing is that if you're talking about an AVM, then you would need to go and look to see, is there edema in the cord? Are there other features that you see? Not in this case, but this is just the most important point was that this is an aggressive hemangioma and it has already caused changes in the cord. And so then they took this patient urgently and they did the surgery for this patient. So you can still see that there in
Multiple
this
body
small,
hemangioma is there, but the outside one is removed
they
within
have
the canal.
because the hemangioma is not malignant, it's not going to do anything to the
Mm.
patient. But the only thing they need to do is to do this decompression really urgently. So you see, there's still some possible signal, but the cord has a relatively normal caliber here now.
Mm.
So the cord is relatively normal caliber here, but it has they have decompressed it. So this was an aggressive hemangioma.
Yes.
Okay, so going for your last case, let me open that. Okay, it's your last case.
CT abdomen with contrast showing hypodensity involving segment 5 and 7 of the liver with subcapsular hyperdensities as well. There is multiple linear hypodensities involving the segment 5 of liver. GB is unremarkable. Kidneys are normally enhancing. Spleen also normal. No peripancreatic fat stranding is noted. Vessels are normal. And there is also dense ascites in the pelvis. Left femoral head is also dislocated posteriorly. Um, Based on these things, it's likely a trauma case with liver laceration and subcapsular hematoma with the left femur dislocated posteriorly. It's a dashboard injury, but I want to see the other phases to see any active leakage of the contrast, which I cannot see in this image. And I would like to see the bone window to see any other fracture, and also the lung window to.
Yeah, for the sake of time, we can ignore those, but I can show you this. So this is.
Mm. Portal vein is normally contrast opacified, and hepatic veins also appear remarkable. However, middle hepatic vein, it's also normal. So it's a severe injury. I think it's. I would like to measure the size of the lesion as well, and multiple liver lacerations, and it's shattered almost in the center. So I would urgently call the surgical team on call and to manage that patient, check the vitals, and further manage it.
So do you know about some classification for this? I'm going to take the mouse a bit, sorry.
Okay. Yes, from the laceration point of view, if it is less than 1 centimeter, grade 1, if 1 to 3 is grade 2, and more than 3 is grade 3 with active leakage, and that's, I think, 4.
Yeah.
It's
So for spleen, liver, and kidney, you should know the American Association for Surgery of, I think, Trauma. It is the AAST classification, and you should know that. And because that depends upon the management of this. Okay,
Mm.
so 1 minute. So what is this?
This is a vessel, but um,
So when they did this study, the patient was too sick for them to take the patient and repeat the study again.
okay.
So they had to take the patient for embolization.
Mm.
This is like, you know, that this is the vein and this is the artery. So there was a contrast extravasation here because you see the vessel here, and this patient was actively bleeding, like they were pumping blood into him, and his blood pressure would drop. He was very, very unstable. You can see from the degree of
Yeah.
hemoperiton. This scan was acquired in minutes, but the patient kept getting sicker and sicker. So when we suggested that we bring the patient back and do an arterial study, they said it's not possible.
Okay.
So this is active contrast extravasation and hemoperitoneum and a significant liver injury. And from the grading point of view, it's 7.1 by 7.7 centimeters, what it is. So it is grade 4.
Grade 4 injury with active
Grade 4.
bleeding.
Okay, so if there's vascular injury with active bleeding and
It would
breaching
be
the
grade.
liver into the peritoneum. So you see here,
Yes.
see there? So that is from where all this blood is. See that? So that is grade 4.
Yes.
Okay. So that's a very good, a very nice pickup. And you did talk about that fractured femur as well. So very good. Okay. So overall, you're doing really well. And I think that you are ready for the exam whenever you're going to be appearing in it. And still as much practice as possible until what do you call it, until you get there, right?
Okay.
So
Thank you.
yeah, so but otherwise very good. For the candidate 4, I'm just bringing out your things. Okay, so candidate 4, we can start for you. Any questions, sorry, in that one? So candidate 1, sorry, 4.
Yes, ma'am, I'm here. CT scan brain axial sections taken in the unenhanced phase. Axial and the coronal images are provided. In these images, I can appreciate that there is dilatation of bilateral lateral ventricles, which is more pronounced as compared to the extracerebral CSF spaces. Moreover, I can appreciate there is almost symmetrical bilateral hypodensities are noted in bilateral corona radiata. Ma'am,
Are you able to control it?
yes, ma'am, I'm requesting.
Okay, sure, here.
Okay. Yes. Ma'am, I'm unable to scroll these images.
No problem. I can do it for you. Let me
Okay.
do that for you.
Okay. Okay. So in this image, I can CT scan brain axial sections taken in the unenhanced phase. In these images, again, I can appreciate that
Hypodense areas are noted in bilateral basal ganglia as well as in the left corona radiata. These are more so prominent on the left side, along with dilatation of the bilateral lateral ventricles. I am looking at the third ventricle is also dilated.
I would ignore
May
the
I know
ventricles.
sorry, ma'am?
I would ignore the ventricles for now.
Okay. Okay. Ma'am, may I know the history of the patient?
The patient came with altered loss of consciousness. She's a 55-year-old female.
Okay. Altered consciousness. So, considering this bilateral parenchymal hypodensities in the 55 years old female patient who presented with altered consciousness, my differential possibilities could be this could be the multiple infarcts in um, different territories. Other possibilities could be infections. But I don't appreciate any other. Can you scroll? I don't appreciate any mass lean.
Okay, so what do you want to do next?
I would like to look for the contrast enhanced images.
Which contrast enhanced images?
If MRI is, then MRI would be better.
Okay, so I have a CTA.
Okay. These are the CT scan images, contrast enhanced images of the same patient. In these images, again, I can appreciate that there is normal opacification of bilateral dural venous sinuses. I'm looking at the arteries. Bilateral. But the previously mentioned hypodense areas, they do not show contrast enhancement. I would like to see the brain.
So this is just a sum up of an image, MIP image, so that you can decide, do
Okay.
you see an abnormality in the
Okay.
vessels or you do
Can,
not?
can I zoom it, please, because the image is a bit small.
Yes.
Or, oh, yes. Yes, in the MIP images, I'm looking at the bilateral HCA. They appear normal to me. And now I am looking at the dural sinuses. They also appear normal. Bilateral MCA, they are normal. Basilar artery is normal.
So vessels are normal.
Yes.
Okay,
What I can see, the vessels appear normal.
now what do you want to do
No,
next?
I can see there is an abrupt termination of left MCA. Left MCA.
Oh, no, 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 no.
No, okay,
It's
okay. No, this is
because
scrollable.
of
Okay.
where I stopped.
Yes.
Yeah.
Okay. I don't appreciate any aneurysm or any filling defect in these vessels.
Okay.
So
What would you like to do next?
then I would like to see the contrast to do MRI of the patient.
Okay. And in MRI, what do you want to see? Which sequence do you want to see?
DWI.
Okay.
MRI DWI weighted images of the same patient. In these images, I can appreciate that there are multiple multifocal areas of diffusion restriction, which are seen in the bilateral periventricular white matter in the basal ganglia as well as in the right external capsule. They are showing the diffusion restriction and corona radiata as well. But on the T2, no, diffusion restriction is noted in the external and the internal capsule as well.
So you decided that these are infarcts, right?
Yes, I think these are infarcts.
Okay. Is there anything? Sorry, I'm trying to window this image.
This is the contrast enhanced MRI image of the same
Okay.
patient. In this image, I can see that these lesions show contrast enhancement and they show the contrast enhancement in a peripheral thick irregular contrast enhancement. But I
Okay.
don't appreciate any associated edema. But considering this contrast enhancement pattern as well as the diffusion restriction, um, differential possibilities, this could be the abscesses,
Okay.
but they are showing a thick enhancement. Other possibilities could be demyelinating plaques.
Okay.
Mets is less likely because they do not show any edema. I don't appreciate any mass effect, any associated significant edema. Atypical infections like the toxoplasmosis could be they could be considered, and
Okay.
possibility of lymphoma. But the lymphoma usually hyperdense on the CT, so it's less likely possibility in this case.
Okay.
And mm, so next, I would like to review the clinical notes for any previous history or previous imaging, if available, and to see look for the immunocompromised status of the patient.
Okay, okay. So I'm going to show you is another thing, and I want you to tell me the diagnosis.
Okay.
So start from here.
These are the CT scan abdomen axial sections taken in the contrast enhanced face of the same patient. In these images, I can see there are multifocal hypodense areas are noted in the bilateral kidneys. Significant few hypodensities are also noted in spleen.
Mhm,
Significant atherosclerotic changes are noted in aorta.
mhm.
So I'm suspecting there could be the multiple infarcts.
Okay. So then,
Then this could be so there could be the multiple. So I'm suspecting, and now again I'm thinking about infarcts
okay,
or the thromboembolic process.
okay. So let's go back to the same image again. So then, 1 minute. Sorry, it's a big, it has too many studies. So again, somebody really tampered with the window of that. Okay. So then what is this?
These could be the subacute infarcts because they also show enhancement.
Exactly, exactly. So now you see that there are multiple infarcts. So what does your workup include? How are you going to manage this patient?
I would like to refer the patient. I would alert the referring physician about my findings and would recommend echocardiography to look for any thromboembolic phenomena going on in the heart, and would look for would urgently no echocardiography and as this is a diffuse process involving the bilateral kidney, spleen, atherosclerotic process. Uh, so next, I would involve the IR team to look for any for revascularization therapeutic.
So I will stop you here. I'm going to tell you about this case because this is really very, very important. A very important case. So this patient presented with altered level of consciousness. She had bilateral basal ganglia abnormalities. When you have a patient with altered level of consciousness, bilateral basal ganglia abnormalities, it has a very, very important differential diagnosis, which you need to start to think about and roll about. And as you go along, then things start to become clear. So, of course, it could have been a vascular occlusion. And if a vessel was occluded, do you know which vessel would have been occluded to have brought this abnormality? We didn't see a vessel occlusion in this case, but if it was
Yes, ma'am.
supposed,
It could be lenticulostriate branches of AC or MCA.
well, okay, but usually the artery of Percheron is the one, or the basilar tip is the one that might have also brought on this picture. Okay, those are two things. Then the other cases that could bring on bilateral basal ganglia abnormalities, you have to really be aware about is the carbon monoxide poisoning, right?
Mm-hmm.
So carbon monoxide poisoning, methanol toxicity, these are the things that can give you bilateral basal ganglia abnormalities. Other than that, this was infarcts, okay? And then you have other differential diagnosis, which is the hypoxic ischemic injury, which is very, very extremely important. I have a case of that, but I didn't bring it up. I should have brought that for you to see as well. So bilateral basal ganglia differential, you have to have it on your tips in children and in adults because it is a very, very high yield thing, okay? So in children, I don't remember it well, but I'm trying to think. Okay, so in children, I think it is those like Lee's disease or those kind of differentials that come into it. So it would be that. But in adults, it could be like intravenous drug abuse. It could be what you call it, carbon monoxide, methanol. Then we talked about the vascular, and this was generalized. This was thromboembolic, right? So this patient. So whenever you have these multiple infarcts. And you have basically you have to rule out is the hypercoagulable states. You have to rule out malignancy. So and then you have to rule out cardiac. You have to do cardiac workup basically, which is very important. So this patient's cardiac workup was negative, but she had a prothrombotic state. I believe pancreatic cancer is one very common cause of patients' presentation with infarcts, and then when they present and then we image them, we find that they have a pancreatic cancer, which led to like even pulmonary embolism, brain infarcts, and DVT. So I have one patient that presented with three of these. So the hypercoagulability states are, of course, your primary things. I remember two only. No, so one is lupus, and then there's the protein C and S, but there are a couple of other, I think, maybe antiphospholipid. I don't remember all of those things, but should know a bit of differential on that as well. So this was that case. So this is how it evolved. It went on, and so this is subacute infarct. And then when I showed you the diffusion, I was trying to make you see something. I wanted you to comment on one thing, and that was that the infarcts are of different ages. So if you recognize that, so you see that this is bright, this is not as bright. And there's one here that looks kind of chronic. So this one looks more chronic here. So they are of varying ages, and then which makes you think that it is either thromboembolic or a prothrombotic state because the patient keeps getting infarcts at different. So this patient did not regain consciousness. I mean, like she was comatose throughout because like the process kept repeating itself. So this was any questions about this case? And yes, basilar tip occlusion can also cause a basal ganglia infarcts. Ventricular dilatation, she is 57. They didn't think much about it because she does have some volume loss as well. So you see that for 57, she has more volume loss. And hemorrhagic infarcts, that one I don't know about. I will see whether we don't see any hemorrhage here, but here we can see the SWI images, the susceptibility. So maybe some hemorrhage with this one, but not mostly. So these are the other infarcts. Subacute infarcts can enhance, don't get confused. When you made your arteries are all fine, yes. So when you made your diagnosis that you thought they were infarcts, then you got confused because of the enhancement and you went off. So what your first thought is always correct. You have to apply this in rapid reporting and in everything. So what you call it, when you're doing rapid reporting, when you think something is normal, then don't get confused and turn it into abnormal. That's very important. In imaging, when you're describing something, you make an impression, then try to carry it on unless there is like you have quite significant evidence to say that it is not so. So here, these are infarcts as well. So these are multiple renal infarcts. There are splenic infarcts, but the vessels were patent. So even the splenic artery, you can see it going here, is patent. And so because of this prothrombotic state, the patient kept forming some kind of thrombi and emboli that cause this thing. So these are renal infarcts, severe renal infarcts. So this is a thromboembolism, just clotting everywhere happening because the patient is hypercoagulable. That's why, and it's variable. Somebody can infarct the liver, somebody can do the spleen, somebody here he has the kidneys. She has the kidneys as well, and then she had in the brain as well. So it just depends upon, and sometimes these, because when there is atherosclerotic disease, so here you see the atherosclerotic disease, so the blood flow is already slow, so that would predispose the kidneys to more of this. See, she has so this is exacerbating the thrombosis. Basically. So that's why she's having more in the kidneys because of the severe atheromatous disease and slow flow probably. And then in the spleen, which is a very, very common cause of infarcts, as we know. So abscesses and infarcts can both get peripheral enhancement. But what you call it, abscess, it's going to be cleaner than what we have here. So let's go back to our infarct. Where's the post-contrast image of the MRI? I do have brain abscess somewhere, but I would have to search for the number to for the thing to show you how brain abscess would look. 1 minute. So this is not typical of an abscess. Like you would not see the abscess like this. And this is more because you saw here the diffusion and all that. Sorry. So this was an infarct. And because they're different ages, we're quite confident that these are infarct because the brain is not going to be like this clean in an abscess, and you're not going to see so many abscesses concentrated. So carotid in base of skull is also atherosclerosed. So there would be atherosclerotic changes everywhere. I have a companion case I can show you really quickly. I think somewhere here, which is a brain abscess. 1 minute. Let's see the stroke. So somebody's asking if there is atherosclerotic disease. Yeah, so has atherosclerotic disease at the bulbs, but otherwise at the skull base, no. Skull base, the carotids look okay. There is some atherosclerotic disease. So I'm going to show you one case quickly. Let me find that one, which is a brain abscess ruptured. Okay. Okay, so I'm going to show you this myself for the sake of the time. So this is a case of an abscess. See that T2 rim there?
Yes,
So you're going to see that. And then let's look at the diffusion here. So see that? Can you see that there?
yes, ma'am.
So when there's an abscess, you're going to be able to recognize it. See the amount of edema? So these are all the points that are against that much. So this is all rupturing. It has ruptured into the ventricle here. And it's all in the ventricles, and you see the amount of edema here. So this is an abscess which has ruptured into the ventricle. You can see the abscess here. You can see it going into the ventricle here. This is all ependymitis, and you see the way it is different. This case is different from that case, and then this is all pus in the ventricles. See that?
Mm.
And then let me bring the post-contrast images here. So you see that? See that?
Yes, ma'am.
You see it going into the ventricles. So this is all pus in the ventricles. So this is, and see the amount of edema there.
Mm.
So ventriculitis and ependymitis. So ependymitis is the ependyma of the ventricles. It is not enhancing in this case. Let me bring out a T2 weighted, where's the T2 image? So this would be the ependymal lining is the lining, and ventriculitis or ependymitis is going to be like more, I think it should be more or less the same thing. I also got a bit confused. Ventriculitis and ependymitis. Just quickly see that. Ependyma is the lining of the ventricle. So and ventriculitis, I mean, it means, I guess, all of the ventricle. So when the ventricles enlarge like this is, that would be ventriculitis because of all this inflammation going on. So that is ventriculitis. And when the lining of the ventricle enhances like this lining, like in the post-contrast image, like this inside lining, this one, then that would be ependymitis, the lining of the ventricle. If this enhances, that would be ependymitis. Because the ventricles are dilated and they have this pus and there is this in all this edema, so that is ventriculitis, I guess. So I don't know if there's a case on Radiopedia for that to see, or if you can see that yourself. And I'm also going to look at one so that I can also kind of let me quickly see if I can. Sorry. Sorry, I'm just trying to get the mouse. Okay, so I can open a case here. So ventriculitis and ependymitis. Okay, ependymitis. Okay. I think this one looks like a nice one. Let's look at this one. So are you able to see this? So see that?
Yes, ma'am.
So this is the lining of the ventricle. So this is ependymitis, and the fact that the ventricle is also enlarged and dilated, so that would be, so here there is some enhancement here, that thin lining of the ventricle. It's not as good. Let me see another one, another case. Post-operative. So this is post-operative enhancement, and okay, so let's look at this one. Let's see. Can you see this pneumococcal meningitis with ventriculitis? So
Yes,
this is the thing in there, and let's look at the MRI. These ads are so many that it's very difficult to do something on Radiopedia. Hate them. Okay, so then these are the pus CSF levels, okay? And let's look at the flare. So on flare, you see them well, and then post contrast. Okay, so let's look at this. I don't see that enhancement that well. Let's go back. Pyogenic meningitis, cerebral abscess. Okay, let's look at this one. So, okay, this is a very good one. See that? So that is ependymitis or ventriculitis, however you put it. See the way that is enhancing and this is not enhancing. So that's ependymitis, or and then ependyma is enhancing and it is leading to ventriculitis basically. So I think they can be used synonymously, something like that. Okay, so this was this case. There's some more questions. I got it. I was trying to see demyelination. Can it be in the differential of the first case? Is that it? For the first case, which we are originally looking at, because this is the one I just showed you a companion case, right? So when you see this rim on T2, you're quite dead sure that this is an abscess in the amount of edema. And the one we're looking at, let me pull that up again. Okay, so here we have this. And
Ma'am, we
then
can't see the screen. Ma'am, we can't see the screen.
I'm going to share. Just give me a minute. I'm just loading the images again. Sorry. So this was our original one. And yeah, so there's lots of difference here between these. Let me see if we have a T2 or a flare image. So see the difference between these infarcts and that abscess?
Mm.
Like, see how clean the brain is?
Yes.
See that? So this is the infarct, and I'm going to bring the abscess now. So that was which one? Okay. Okay, so then let's bring this one here. So this was the abscess. See that rim there?
Yes.
And you can see it on T2. See that?
Mm-hmm.
And it is always thin medially. This rim is always thin medially, and that is why it ruptures medially. And that is where it probably ruptured here. So this is an abscess. You can see the difference between the abscess and the infarct. See? Is there any more question for this case? Or the one we just saw, the multiple infarcts? No, okay, so then we can go on to our, there are some questions in the chat. Sorry, let me just look at this. But the original case, demyelination, I don't think so. It doesn't look like demyelination. So for demyelination, you go to the, for the original case, if you had gone, you would see that it was very much concentrated in the basal ganglia. So demyelination, it has to be juxtacortical, it has to be periventricular, and then you see posterior fossa thing. So it's not demyelination. No, there's no question about demyelination in that. Okay, so we're going to go to your second case now, and this is uh, okay. So this is your second case.
Okay. X-ray abdomen frontal projection of a skeletally mature patient. In this X-ray, I can appreciate that there are few surgical clefts are noted in the right hypochondrium. Moreover, I can see that few dilated gut loops are noted, which are likely small gut loops. And they're predominantly seen in the left hypochondrium as well as in the central abdomen. However, I can see air is seen in the large gut loop, in the location of the large gut loop. I can see free air below the right heavy diaphragm. I'm looking at I don't appreciate any evidence of pneumobalia or portal venous gas in this image. Bones appear unremarkable to me. So in this X-ray, my findings are in favor of small bowel obstruction with pneumoperitoneum. Next, I would like to proceed with contrast-enhanced CT of the patient to look for its cause. CT scan abdomen. Yes, CT scan abdomen axial sections of the same patient taken in the post-contrast enhanced phase. In these images, I can appreciate that there is a soft tissue density masses noted in the right iliac fossa and with a significant mesenteric haze in the pelvis. I can appreciate that this mass is predominantly shows a homogeneous enhancement. And I don't appreciate any upstream dilatation due to this mass. In the coronal images, I can appreciate that this mass is likely originating from cecum. And but I would like to look for ileocecal junction. And I think this mass is originating from the cecum and probably the terminal ileum with a large exophytic component which shows almost homogeneous enhancement with no significant internal necrosis. And it is not causing any upstream dilatation. And I'm looking for any significant lymphadenopathy in adjacent mesentery. I saw few, I can see few mesenteric lymph nodes which are rounded in shape in vicinity. Yes, and they show the irregular borders. So I suspect these are the metastatic lymph nodes. And the lumen of the cecum is preserved. However, the ileal lumen, if it is involving the ileum, then it's not preserved. So considering the appearances, my differential possibilities include it's likely a lymphoma involving the terminal ileum and the cecum, as it is not causing any significant upstream dilatation, along with few lymph nodes. No, I would like to see I'm looking at the vessels to look for any vascular occlusion, but I can see the vessels show the normal enhancement. Now I would like to see for the lung window to look for pneumoperitoneum.
So you already saw that, right? So for the sake of time, what did you miss on this X-ray?
Mortal
Okay.
lucensis in the right iliac fossa.
Okay, I can come to it later.
Yes,
So you
ma'am,
already
there is.
saw the free air. You already
Mhm.
saw the free air. So can you proceed? Can you tell me your management?
So next, I would like to convey my findings to the referring physician and would recommend a CT guided or the endoscopic biopsy, colonoscopy with the biopsy of this mass for the definitive diagnosis. Moreover, I would like to go do completion staging CT chest and and would refer the patient to the oncology MDT for further management and
So
planning.
what is the free air telling you?
Oh, yes. This patient is, I will urgently convey my findings to the referring to the surgical team for the urgent surgical laparotomy because I'm suspecting perforation,
What perforation?
gut perforation due to this mass. It could this mass. There are a few possibilities. Either the gut is perforated or the mass is perforated. As I don't appreciate any dilated bowel, so bowel is there's less likely possibility of bowel perforation. I'm suspecting it could be a mass perforated mass.
Okay, so I'm going
Uh,
to back to your case. So you missed this.
Yes.
You saw the loops here, small bowel, and then you said small bowel obstruction. So then you should, if you're suspecting small bowel obstruction, 2 or 3 things, cholecystectomy clips, so that gallstone ileus business is out. Then you very nicely talked about the pneumobilia thing. There is some pneumobilia, but we're going to ignore that, okay? So then you said that you didn't talk about this, you talked about pneumoperitoneum. So this is a cecal mass that has perforated. And then you said because it's not causing obstruction, so you said it's a lymphoma. Whereas what happened is that this mass was causing obstruction and then it perforated, and that is why this bowel is not decompressed. Okay. Initially, when it came, the patient was obstructed. Another thing is that you do see this pneumobilia here, this one, but it's unrelated. It's because of our cholecystectomy. It's not significant. So this is a perforated cecal adenocarcinoma. So, like I said to you, do not talk about staging in the first sentence. First sentence is this is stage 4 disease already because it's perforated, right? So what are you going to talk about is that you have a perforated cancer and you need to immediately tell send the patient to a surgeon, and then you will also initiate the oncology workup and all that. So this is one example that I wanted to show you. I spoke about it, but I wanted to show you as well so that you always remember that when there is a perforated malignancy, it is an emergency. You do not think that staging is important at that point.
Okay.
So any questions in this? Okay, so we go to your third case then. Okay, so if you want to scroll, that's fine by me. If you want me to scroll, I can do that. So the patient came with right upper quadrant pain.
Right upper quadrant. Okay. These are the ultrasound grayscale images of a patient who presented with right upper quadrant pain. In these images, I can appreciate that gallbladder. I want to look at the gallbladder. I feel that the gallbladder is distended, significantly distended. I can see that its wall appears echogenic, causing posterior acoustic shadowing. And in one of the image, I felt there are the few foci in the wall. And can you scroll it? Yes, there are the few echogenic foci are also noted in its wall. So and they are also causing posterior acoustic shading. So I'm suspecting this is the air in the gallbladder wall. Moreover, I can appreciate there is a subtle hypodensis noted in the adjacent gallbladder fossa in the adjacent liver. So I'm suspecting it could be a case of gangrenous cholecystitis, or it could be emphysematous cholecystitis. Although I don't appreciate air inside the lumen of the gallbladder, I don't appreciate any calculus inside the gallbladder. So this is it could be a case of emphysematous cholecystitis. Next, I would like to take the history of the patient. The patient is diabetic.
Okay.
Ma'am, if is the patient diabetic?
Well, what do you want to do next? I will not answer that question, right?
This is an emergency. I would urgently convey my findings to the referring physician and would refer the patient to the surgical team.
And do you want to do anything?
Yes, I would like to do a CT scan of the patient to look for the extent of the disease.
Okay.
CT scan abdomen axial sections taken in the unenhanced face of the same patient. In these images, I can appreciate the air is noted in the gallbladder, in the wall of the gallbladder, and the few air loculi are also noted in the perihepatic space, in the subhepatic space. Airflow level is noted in the gallbladder. So I'm suspecting gangrenous gallbladder. Significant stranding is noted in the pericholecystic area. So this is the case of gangrenous cholecystitis. I would urgently refer the patient to the surgical team for urgent management.
Gangrenous cholecystitis.
Yes.
Okay. All right. So the thing is that because of the air, what would you call it?
It's because of air.
So it's an emphysematous
Okay.
emphysematous cholecystitis
With airflow level or with secondary infective changes or perforation?
with perforation. So emphysematous cholecystitis with perforation, right?
Okay. Yes.
And we didn't see any stones on this. Now, what kind of CT is this? Non-contrast CT?
Non-contrast. Yes, ma'am.
Why would the patient be getting a non-contrast CT when the patient is so sick?
Because we can't wait for RFTs, and
No,
these findings can be easily picked on the unenhanced.
no. We never know what we are going to find in the abdomen, right? So it is because the patient is a diabetic. He has elevated EGFR, so they couldn't give him contrast. You can see from the amount of atherosclerotic calcification as well, and the patient was very sick. So we just did it. So this is an emphysematous cholecystitis with perforation. See that?
Mm-hmm.
And it is basically an infective process. So there are no stones in this one. There are no stones, but diabetic patients, for some reason or the other, they are prone to these things. Another thing is sometimes they have gallbladder stasis. Like they don't eat, they are sick. And when the gallbladder keeps distending, it becomes inflamed. Okay. So this is it. So this is a case of, this is an emergency. So when you saw the ultrasound, you have to immediately tell the physician, you think this is what I'm suspecting because it is really dangerous. And then you say that if you think the patient is stable, we can proceed with the CT. And then, of course, you saw that we did the CT without contrast, and it has a very, very high mortality, very high. So in this, this is a male patient, and they say that men are affected more than females. And so what happens in this, the cause for this, you have to be aware of that. Why did the patient get this emphysema? What happened? So it is thought that the cystic artery is the one that there is some vascular compromise associated with the cystic artery, and then you see this this happening, that the blood supply is gone for this. It doesn't have blood supply, and that is why it developed this. It is kind of it is like mesenteric ischemia, but it is gallbladder ischemia. And then it developed like when you have pneumatosis. So here you developed the here in the gallbladder wall, and then it perforated finally. When it couldn't take it anymore, then it perforated. So here you would have wanted to see the lung window, must, right?
Yes,
So
ma'am.
you see all that. That's it. Okay, so that was your third case. So we're done with the 4 candidates, and we saw more than the 3 cases, because I did show you some companion cases, and we had a good discussion on things. So you did really well, and I think that you are kind of ready for the exam. Just need to practice more. You need to what do you call it?